So the common question that we have to know in this particular scenario is what is the diagnosis of this patient? That is the first question the examiners will ask you if this case scenario is given in your practical exam. Now the diagnosis that you have to give here is not preeclampsia. Please remember that because we do not know whether the patient has a proteinuria in urine or not. Okay, so we have to say it is a pregnancy complicated with hypertension or hypertensive disorder complicating pregnancy. That is our diagnosis. The second question is how will you proceed with this patient? Now here she is in a severe hypertensive state because of this 210 by 120. The blood pressure according to the category of hypertension which we saw in our last class, stage 1 or grade 1, grade 2, grade 3, she is in the grade 3 or severe category. So last class you go through and you remember that last what we discussed, regulation of blood pressure and hypertension. This comes under very severe category of stage 3 of hypertension. So even if he is not pregnant, this patient with this such high BP requires immediate treatment. So the problem here is to treat this high BP. So this patient cannot be treated as outpatient. So first and foremost thing, the answer that you have to give is, I will admit the patient and start treating this hypertensive crisis or severe hypertension by parenteral antihypertensives. Here, your oral antihypertensives may not be immediately taking effect. So, we have to, of course, we will be asking the history of whether patient already has been diagnosed with a high BP in the antenatal period and whether already has she been taking any medication. And after ascertaining this, definitely she will require IV antihypertensives to control the blood pressure. At the same time, we will have to monitor the welfare of the fetus also because it is only 34 weeks of gestation. So we have to make sure that the fetus is also viable and stable or not. So these are the two important things that we have to focus our attention on. The third question is the description. Hypertensive disorders of pregnancy. We just now asked that question and clarified that. So four categories of hypertension. One is the pregnancy pre-eclamptic or eclamptic hypertension. The second is pregnancy-induced hypertension, where it is a new onset hypertension occurring after 20 weeks without proteinuria. Third is chronic hypertension, where patient has been hypertensive even before she became pregnant. Nowadays, the age of women getting married is getting older and older because of their job constraints and other things. So we get what is called the elderly preemies are very, very common nowadays. At the age of 35, 37, 38 and all, we are having patients coming with the first time pregnant patients. And they might have been already diagnosed with the hypertension. And the fourth category is chronic hypertension where superimposed preeclampsia is there. So in chronic hypertension with or without eclampsia, the BP is present even before the woman became pregnant. Whereas in the other two categories, the preeclampsia and gestational hypertension, it occurs after 20 weeks of pregnancy. And the reason why it happens after 20 weeks, I told you just now. And then what category this patient comes? So this patient will come under severe category because of the clinical features that she has headache, visual disturbance on BP is also quite high. So how will you confirm your diagnosis of whether it is a preeclamptic hypertension? The most important confirmatory diagnosis is proteinuria. And what happens if this condition is not treated immediately? It may produce complications both to the mother as well as the fetus. So maternal complications, cardiovascular, central nervous system and respiratory complications which are life-threatening and less life-threatening complications also can happen in the various systems. And with regard to the fetus, what are the complications fetus can suffer if this BP is not treated immediately? What are the fetal complications you can anticipate?
small for dates baby. Abruptio placenta is most common, sir.
Abruptio placenta and fecal distress. Okay, those are the two immediate life-threatening things that can happen. And how do you proceed to treat this patient? As I said, you have to admit, start antihypertensives parenterally, then monitor the fetus as well as the mother at frequent intervals for their welfare. And can pregnancy be terminated at this stage? If yes, what are the advantages and disadvantages? The indication for terminating the pregnancy by delivery of the fetus and placenta is very severe life-threatening complications to the mother. For example, an imminent pulmonary edema, or if cardiac failure, or there is a suspicion of cerebral hemorrhage or stroke, then patient has to be the baby has to be delivered immediately. But advantage of delivering immediately is it will safeguard the mother's life. But the disadvantage of delivering the baby at this stage is it may be premature.
Preterm labor.
So unless you have facility for a neonatal intensive care unit where you can salvage the fetus, this may be disadvantages to the fetus. And if planning to allow the pregnancy to continue, what are the advantages and disadvantages? Again, we have already discussed that the baby will have more stability, more maturity to sustain life after birth. And the physician wants to try normal delivery, how can you help? And if planning for elective operative delivery, how do you manage that? If treated as emergency operative delivery, what are the risks and how are they prevented or managed? So this is another question that can be asked. So one by one, we'll just discuss that. If physician wants to try a normal delivery, is it advisable? When will you accept the physician's request for a normal delivery? In that stage, if you agree to the physician's concept or proposal of normal delivery, what is your role in that? Let me explain that a little more. You have admitted the patient. You have started on IV antihypertensives. Now the BP has come to 130 by 80, and patient is free from headache and visual disturbance, and heartbeat is normal. And so the physician says we will go ahead with the normal vaginal delivery. I will probably induce her contractions and try to deliver her. If that is the suggestion after control of BP and mother appears to be now in a safe position with the antihypertensive treatment, and if the physician wants to have a normal vaginal delivery because there is no capillopelvic disproportion or anything else, and fetus also seems to be quite stable. In that case, what is your role in this particular condition when the physician wants to induce labor by giving an oxytocin drip or a syntocinon drip? What is the most important thing that will happen if the mother is induced to have a normal vaginal delivery?
Contractions will increase.
Huh?
Contractions will increase and the pain will also increase. So we should.
Labor pain will happen. Once you start inducing the mother, she will develop uterine contractions, which will be quite painful. And what this pain can do?
It can cause hemodynamic changes. So
it will increase the BP again. It will make the BP shoot up. Okay. So how can you help in this stage?
By giving labor analgesia.
You block the pain by giving labor analgesia. Okay, that's as simple as that. Very, very logical, simple questions. It is not a major complicated question at all. So your role in a normal vaginal delivery is providing the best possible labor analgesia so that the mother does not feel the uterine contraction pain, which can worsen the hypertension or increase the BP, and again revert back to original high BP state. Okay, so that is the answer for this particular thing. On the contrary, if the physician says somewhat may, even if the baby is 34 weeks, we can look after the baby in bringing it like intensive care, and I want to do a LSES and operate, remove the baby. Maybe I will take her up tomorrow morning. Semi-elective, it is not an urgent thing. So, in that situation, what will you do? What is the regular anesthesia you give for any cesarean section, operative delivery? What is the recommended technique? Huh? Any elective
Spinal
or
anesthesia. Spinal anesthesia.
single shot spinal anesthesia with a heavy local anesthetic agent like bupivacaine 2 to 2.5 ml. Okay, that is what we normally do. How many of all of you have given anesthesia for cesarean so far in your training, or not seen at all? The first years may not have had a chance to see. At least as a house surgeon, you would have seen in the labor ward and the OG posting many cesareans being done. You could have assisted or seen in the OT. So mostly they are done under subarachnoid block, single shot subarachnoid block with a local anesthetic like bupivacaine 0.5%, 2 to 2.5 ml that is given. Okay, so the same thing can be done here also, but is it advisable to give the same volume of 2.5 or 3 ml that is given for a non-complicated case, I mean for cesarean, or do you have to modify something in your final technique? A patient with a high BP. Getting worried whether my questions are being understood or not. Are you able to follow my question? Say yes or no, at least I want some answer.
Yes, sir.
Can you
Sir.
please repeat the question, sir?
Will you administer the same 2.5 ml which you normally give for a non-complicated operative delivery, or will you modify your drug administration in a pre-eclamptic patient with a high BP? What is the level
We have
you
to
require
modify,
for
sir.
a cesarean section? What is the level of block that you require by administering the subarachnoid block? Up to what level you require a block of the spinal nerves?
Up to T4.
Up to T4 or T5. Very good. Why do you require what is the nerve supply to the uterus? What is the nerve supply? This is the simple physiology, I mean anatomy and physiology. Nerve supply and the pain perception. Pain perception is physiology part and anatomy part is the nerve supply. What is the nerve supply to the uterus and the lower uterine segment? For the sake of nerve supply, you have to divide the uterus into upper uterine segment and lower uterine segment. What is the nerve supply to the upper uterine segment? That is the body and fundus of the uterus. What is the nerve supply? Lower part, the cervix and the vaginal canal. What is the nerve supply?
So, ovarian plexus is from T10 to L2.
L2. Very good.
Around.
Upper uterine segment is served by T10 to L2. Lower uterine segment is sacred. S2 to S4. Okay? So that is the nerve supply. Then why do you want a block up to T4 or T5? The nerve supply is starting only from T10, T10, T11, T12, L1, L2. But why do you want to block up to T4 or T5 for a cesarean section?
The uterus is increased in size, so there is
Even if it increases, the nerve is going to come in the same segment. It is not going to jump up and go up to T4.
while doing cesarean, there is manipulation of the
Okay. Uterus. Very good. So manipulation, how is it going to affect?
causes
right.
diaphragmatic irritation.
Diaphragmatic irritation.
They will give fundal pressure.
So fundus also
So,
supplied by
fundus-
T10 to L2.
This
What is covering the fundus? Is
skin
uterus
over
an intraperitoneal structure or an extraperitoneal structure?
extraperitoneal.
There is a layer of peritoneum covering the
Covering the
fundus.
fundus.
That uterus is basically extrauterine organ. So when they give the fundal pressure, the part of peritoneal layer which is covering the fundus will be stretched unduly. Okay, and that is the one which is going to cause a discomfort or a mild traction pain. And in order to block that sensation, you need to have a block up to T4 to T5. Otherwise, what will happen? Patient will be very quiet when they make the skin incision at the L1, L2 level, intertransverse, lowest part of the abdomen as a fan steel incision. He will be very quiet until they retract the muscles and then expose the lower segment of the uterus. But once they start giving pressure at the fundus, because the peritoneum is stretched, if there is no block of T4 or T5, at time patient will start complaining of discomfort and pain. So in order to block even that peritoneal stretching pain, you have to have a block up to T4 and T5. Otherwise, it is not necessary to go up to that level because the nerve supply comes only from T10 to L2 for the upper segment and lesser than that for the lower segment. And if it is lower segment, it is totally the or 3 ml for a hypertensive patient. What can happen? And you block up to T5. What is the hemodynamic change that can happen in that patient?
Severe hypotension can occur.
She can have a severe hypotension. So patient who had a very high BP, suddenly crashing her BP and coming down, is it advisable to do that thing?
No, sir.
No, sir.
So how can you modify that? By you have to prevent that peritoneal stretching pain. At the same time, you have to avoid a severe hypotension. So what alteration you can do in your drug administration in the subarachnoid space to achieve both these goals? Normally, in a pregnant patient, the subarachnoid block is given. Will the level shoot up very high or will it remain very low? The spinal subarachnoid block given to a pregnant patient, will it be ascending up to a higher level compared to a non-pregnant woman or not?
Yes.
Yes. Why it ascends up more in a pregnant woman compared to a non-pregnant? These are all the basic questions they will ask you in your Viva. is the reason for the level going higher up. Supposing a patient comes with a severe ascites or an obese patient with a big paunch comes to you for a surgery and you give a spinal, will the level go higher up compared to a patient without ascites and without a big paunch, like your pregnant patient? See, the reason is the subarachnoid space get compressed because of the pressure on the venous system. The subarachnoid space is narrowed. So what will happen if you inject the drug in a narrow space compared to a space which is wider? It will always try to ascend up. Okay, so even a smaller volume normally has a tendency to ascend up higher in a pregnant woman or a patient with ascites or a patient who is obese with a big paunch. All these patients, you have to be very careful while administering a single shot subarachnoid block because the level is likely to go up. So you can always try to reduce the volume in a pregnant patient even if you want a higher level to happen. But more so in a patient with hypertensive disorder, what you can do is instead of giving the normal 2.5 ml of 0.5% bupivacaine, you can reduce it to 1.5 ml, which may not block up to T5. The level may be only up to T12, T10 or T12, T8. So to avoid this discomfort of your peritoneal stretching, what you can do is you can add 25 micrograms of fentanyl, which is preservative free. How much volume will be there if you take 25 micrograms of fentanyl? How much of fentanyl is there in 1 ml?
50 mics.
50 micrograms.
50 mics. So if 25 mics will be
0.5.
0.5.
0.5. So 1.5 ml of bupivacaine with 0.5
0.5
ml
is
of
equal to 25
fentanyl,
mics.
which will make a total volume of 2 ml. If you administer that, you can achieve a block above T10, which is sufficient to manage the pain on the incision of the uterus. At the same time, this 25 mics of fentanyl will take care of the discomfort that is produced by the peritoneal stretching. Okay. At the same time, you can also avoid a drastic fall in BP by the higher level that you want to achieve. Okay. So that is the adjustment that you have to make in a administration of subarachnoid block in all patients with severe preatlantic hypertension, even if they have been treated for the hypertension. Okay. On the contrary, if you have given a epidural for labor analgesia and after a few hours of waiting, there is no response, then the physician decides about going ahead with the operative delivery. In that case, what can you do? Already there is a working epidural is there. What is the normal dose of local anesthetic you give for labor analgesia? Have any of you read about labor analgesia dose regimen? What is the initial dose? What percentage of local anesthetic you give? How much volume you give? What is the level at which you use your catheter? You all read about that? So the labor analgesia, you introduce the catheter at L3, L4 or L2, L3, just like your regular spinal, and then thread the catheter up to the lower thoracic level, T10, T12 level. Okay, and then start injecting first a bolus dose of 5 ml of 0.25 or 0.125. You reduce the concentration. You don't give the normal 0.5%. So you can give 0.25 or 0.125 or the so-called walking epidurals, where you want to preserve the motor function, abolish only the pain sensation. You can even give half of 0.125, which is 0.0625. Okay? That much of lower dilution you can give, and initial 5 ml you give observe for the pain relief, and then increase the dosage by 2 or 3 ml until you achieve a level of block up to the sensory block should be up to T8. And then you can give it as a intermittent bolus doses or a continuous infusion with a dilute local anesthetic with a fentanyl also, and maintain the labor analgesia. In case the surgeon wants to operate and deliver, you can give a higher concentration like 0.5%. A bolus of 10 ml will block produce a more dense block, and even some amount of motor blockage will happen, and you can proceed with the surgery without the need for a subarachnoid block. So a working epidural can be converted into operative anesthesia by giving a higher concentration and a slightly larger volume. Of course, all the time you have to keep the total volume and concentration that you are giving to avoid local anesthetic systemic toxicity. Okay, that is the only answer that you have to remember. Now, how to evaluate the patient? How do you assess the fetal welfare? Of course, Ginny mentioned about the cardiotocograph and such patient's blood pressure monitoring. And then what pre-op preparations are needed to safeguard the fetal welfare if it is to be delivered? Means what is the most important problem if a baby is delivered prematurely? Which system of the baby will be affected? All along we have been talking that we have to wait for
Respiratory
36 weeks.
system. Lungs.
Respiratory
Lungs.
system. So what is the problem that can
Yes,
happen in the respiratory
steroids.
system of the newborn? Respiratory distress syndrome. Okay?
Distress
So because
syndrome.
of
Yes,
the lung,
we have to
what is
administer
the
steroids.
what
We
is
have
the
to administer
pathophysiology?
steroids, sir, for lung fringe.
What is the pathophysiology of respiratory distress syndrome in the fetus? Absence of which particular component in the alveoli?
Surfactant.
Surfactant. Okay, very good. So the surfactant production is reduced, so the lungs will be in a collapsed state. Pardon?
There is a
You able
current
to
cut
hear
in my
me?
area. There is a current cut with heavy rain, sir. I'll reconnect soon, sir.
Okay. Here there is no rain here at all. So what are the drugs used in the treatment of this condition to the mother? So how to make the lung mature? Have to give steroids
The
to the mother.
steroids have to be given 48 hours before the delivery.
48 hours before
Yes.
you have to give that. And what are the various regimens for use of magnesium sulfate in preeclampsia?
Pritchard's regimen.
Pritchard's regimen and one more.
Hello, Anita. Class work anything happen? So what are the various regimens? This is another common question they will ask you. And how to monitor during magnesium sulfate? What are the effects during increasing blood levels? That also she mentioned. When will the patellar reflex will be abolished? Will the respiratory depression will happen? When will the cardiac depression will happen? All the values Ranjini mentioned. And how to treat magnesium overdose? This is another common question you have to be prepared about, which we saw see in the next slide. And how to manage normal delivery in this case, because this is a thing that we discussed. We have to provide a very good labor analgesia. And which regional anesthetic is suitable for cesarean section and how it is administered, that is what I described now. If GA is needed in this patient, how to administer that. Most of the things described by Ranjini are already there. I will again go through that. And what post-op care is required. They can have a eclamptic fit given after delivery of the fetus up to 48 to 72 hours. He mentioned 24 hours, but better to be safe, keep the patient under observation up to 72 hours, when eclampsia can happen. So sometimes patients who have continuing high BP should be monitored in an intensive care unit, and if necessary, they should be given the calcium sulfate should be continued in the post-delivery period also. So points that you have to keep in mind is what is the definition of PAH, what is the pathophysiology, what are the clinical presentations, how to make a decision in a patient with the preeclampsia, what are the monitoring and management we have to do, what are the pre-op investigations that have to be done, what is the delivery management for both the normal vaginal delivery as well as operative delivery, what are the complications and their management. So these are all, and what are the allied topics that normally will be discussed in viva examination. So it is defined as a new onset hypertension after 20 weeks of gestation. And how are the hypertensive disorders classified? Already we have seen preeclampsia and eclampsia, which is occurring after 20 weeks plus proteinuria. Then only it is diagnosed as preeclampsia. If there is an epileptic fit, it is called eclampsia. So until there is no fit, it is called preeclampsia. And pregnancy-induced hypertension is onset after 20 weeks, no proteinuria. And chronic hypertension onset before 20 weeks. And usually it is a essential or a secondary hypertension has to be ruled out. Just like your other hypertensive patients, you will have to rule out what is the cause of this hypertension. And some of the patients who already have a existing hypertension may develop a preeclampsia, where proteinuria will occur after 20 weeks. But blood pressure would have been high even before that. So these are the 4 categories that you have to remember. And the presentation types of preeclampsia can be primary or secondary hypertension, white coat hypertension, and masked hypertension. Does anyone know what is masked hypertension? And what is white coat hypertension?
White coat hypertension is in presence of the doctor.
Doctor or nurses, whenever they take, it is high, but at home or other conditions, it is normal. Very good. So ambulatory blood pressure is normal, but hospital readings are high. What about masked hypertension? It is almost the reverse of white coat hypertension, where hospital readings are normal, but home readings will be high. That is called masked hypertension. So masked hypertension is an individual's blood pressure readings are normal during medical checkup at the doctor's office, but elevated at home or in other environment. That is called something exactly diagonally opposite to white coat hypertension is called the masked hypertension. What is HELP syndrome and who coined this term? What is the expansion for this HELLP, HELP? H stands for hemolysis. EL stands for elevated liver
liver
enzymes.
P stands for low
low
platelets.
platelets.
Low platelets.
So 3 things have to be included in that. So it's a variant of eclampsia. Very, very severe form of preeclampsia is HELP syndrome, and it is hemolysis, EL elevated liver enzymes, LP low platelets, and it was the term coined by one Dr. Weinstein in 1982. Okay, this is the pathogenesis of preeclampsia. It is a 2-stage procedure. Abnormal placentation and endothelial dysfunction is the basic thing. The stage 1, the placenta is not formed in the normal way, and vascular remodeling. I told you the spiral arteries from resistant vessel, it has to become capacitance vessel. That is not happening. So there is a decreased perfusion to the placenta, and this happens because of genetic nature of the mother or the behavioral and environmental factors are being included in that. And it is stage through what happens, this preeclampsia with the endothelial dysfunction starts affecting the other systems in the body, which results in the because of the vasospasm and activation of coagulation cascade forming microthrombi. And this produces a imbalance between whenever there is a low blood supply, nature always tries to produce new vessels, which is called angiogenesis, to improve the blood supply to that organ. So there are factors which support the angiogenesis, which are called pro-angiogenic, and factors which try to avoid or prevent that, which is called anti-angiogenic. So this imbalance is also there. And the most recent concept here is there is normally these two factors, vascular endothelial growth factor and placental growth factor, they help to form new vessels. Whereas there is another substance called placental soluble fragments like tyrosine kinase, which is anti-angiogenic, which prevents the formation of new vessels. So again, the development of preeclampsia has been attributed to the imbalance between the growth factors and the anti-growth factors like soluble fragments like tyrosine kinase. Okay, so this picture will tell you these are the causes, genetic factors, immunological, environmental factors causing first abnormal placentation, which leads to placental hypoperfusion, which leads to nature trying to rectify it by forming new vessels, and some factors trying to encourage that, some factors trying to block that. The encouraging factors are the growth factors, and the factors blocking that effect is the soluble fragment like tyrosine kinase. Ultimately, the anti-angiogenic factors supersede the growth factors, and that results in endothelial dysfunction, which also produces its effect on the systemic vascular dysfunction. So this is the placental failure of placenta to get implanted properly is called the first stage, and because of that, resulting vascular damages and endothelial dysfunction is called the second stage. So this is how the pathophysiology is described. Now this picture will nicely give you about the spiral arteries, which have the normal muscular coat and the endothelial coat, and this is the myometrium in normal frequency. What happens? This vessel gradually loses all the muscular coat and dilates and becomes a capacitance vessel. Whereas in preeclampsia, you can see the muscular coat is still remaining in the decidua, and it is not dilating as much as this. So the spiral artery still has it is like a resistant artery controlling the blood pressure. So the blood flow is drastically reduced compared to the normal one. So the placenta goes in for ischemia. And the failure of conversion of small caliber resistant vessel to large caliber capacitance vessel. This is in one sentence you can describe the whole change that is happening in the spiral artery.
Sorry, sir. Just now I
Huh?
have connect. Sorry, sir. Just now I have got the current, sir. Just now I could get the clear network, sir.
Okay, you are listening, no? I'm just taking
Yes.
the class on producing. I'm not asking any questions. In between only
Okay,
I'm
sir.
asking
Yes.
the questions. Okay?
Okay, sir. Yes, sir.
Right.
Yes, sir.
Just watch the screen, and if you are able to visualize the PPT, you just watch that.
Okay, sir.
And these are the things that are happening in the changes that happen. Abnormal placentation leading to ischemia and hypoxemia. So endothelial growth factors are trying to produce more vascular formation, but they are all suppressed by the soluble fragments like tyrosine kinase. And so what the changes that are happening, this also produces a lot of oxidative stress, and all the damage that can be caused by hypoxemia is being done there. So the net effect of this is vasospasm, capillary leak, activation of coagulation. These are the three important changes that happen because of the pathophysiology that is happening in preeclamptic patients. Now, according to the stage at which it happens, the preeclampsia nowadays is classified into early onset preeclampsia and late onset preeclampsia. So if the changes occur before 34 weeks of gestation, that is called early onset preeclampsia, and it is primarily caused by the syncytial trophoblast stress leading to poor placentation. But some patients who have a normal BP or a moderately elevated BP after 20 weeks without any severe proteinuria and all those things, they suddenly become so develop a very severe hypertension after 34 weeks, and they show more proteinuria also after that. They are called late onset preeclamptic patients. So if all the changes happen before 34 weeks in a very severe fashion, it is called early onset preeclampsia. And if they happen after 34 weeks, they are called as late onset preeclampsia. The advantage of late onset is during the early period, because the BP is not that much high and the pathology is not that severe, the growth of the fetus will be almost normal. It will not be, affected in late onset. Whereas in the early onset, it is associated with fetal growth restriction, and the placental dysfunction is because the duration of placental dysfunction is more. So for that reason only, this classification is given as early onset and late onset. And based on the BP, you can grade the severity of your preeclampsia, just like your stages of hypertension. It is mild to moderate and severe based on the BP. And symptoms associated with severe preeclampsia are headache, visual disturbance, and nausea and vomiting, sudden swelling of face, feet, and hands, and brisk, deep tendon reflexes. All these things can be the feature. And the various systems that are affected in patients with established preeclampsia, where they have hypertension after 20 weeks with proteinuria, the hematological changes, mainly they develop thrombocytopenia, altered coagulation profile, and in very severe cases, they will have hemolysis, low platelet, and elevated liver enzyme. And they can have biochemical impairment. And the kidney, they will have altered uric acid level, creatine, sodium, the urea levels also will be high. They will have proteinuria, and elevated urine protein creatinine ratio also will be altered. And in the liver, they will have low albumin, low glucose, elevated enzymes, and bilirubin also will start increasing. What investigations you have to do is you have to do a blood test and full blood count with emphasis on platelet count, because as I said, thrombocytopenia is common, and clotting screen or coagulation profile has to be done. If the platelets is less than 100,000, 1 lakh, and the request for blood film, if it is a health syndrome is suspected, which may show spherocytes, histiocytosis, triangular cells, and Burr cells. These are all the abnormal cells that you will find in the peripheral smear. And urea and the electrolyte, the serum creatinine, that urate will have to be measured. For liver function, you have to estimate the enzymes and check the glucose. If ALT is more than 150, acute fatty liver of pregnancy or diabetes can be diagnosed. And urine test, urine dipstick, you can find out whether it is a trace 1+, 2+, and according to that, you can decide what will be the exact value or quantification of the protein in the urine from 0.1 to 5, more than 5 grams in 24 hours per deciliter you can have, or in milligrams also you can have. And the urinary protein creatinine ratio from a random sample less than 30 excludes significant proteinuria. More than 30 may be suggestive of that. But definitely after 24-hour urine collection, if more than 300 milligrams of protein is excreted, then it confirms and quantifies severe proteinuria. So this is a very important value asked in the examination. More than 300 milligram of protein in 24-hour urine collection is very diagnostic and pathognomonic of preeclampsia. And to rule out any UTI, you have to take a mixed question, and the urine output to be accurately monitored, because acute kidney injury is very common in preeclampsia. And nowadays we are using USG in all the fields, and in preeclampsia, USG has a very important role. It may help you to assess the airway because there will be a lot of edema in the airway and you can diagnose the size of the glottis and other things where mucosal edema will make it narrow. That is why Arjuni said you may have to use a smaller size tube than the one that can be taken in by a non-pregnant woman. Pregnant women usually accept only a smaller size tube. And the gastric volume measurement is another important thing that is done by the USG so that we can find out the status of full stomach. Then sometimes when there is a lot of edema, the limbs, vascular access, peripheral vascular access may be difficult. In that situation, you may have to have a central access, which will be helpful by doing a ultrasound. And lung fluid assessment in cases of impending pulmonary edema. The pulmonary edema that happens in preeclampsia, is it of cardiac origin or non-cardiac origin? Are you all hearing? Yes or no at least?
Non-cardiogenic, sir.
Non-cardiac, because the capillaries are leaky. That is what I told you in the pathophysiology. Vasospasm, capillary leak, and what is the third thing I told you? The net effect of your pathophysiology. So it is a leaky edema. It is mostly not due to cardiac origin. And there will be raised ICP because of the edema all over and produce intracranial edema also, intracranial pressure is raised. So optic nerve diameter measurement is also a very important thing that you can measure by USG. And when the patient has frontal edema, spinal may be difficult. That situation for a central neuraxial blockade, you may use USG. So these are all the indications for USG use in the preeclamptic patient with lot of edema. What is ROSE scan?
Rapid obstetric screening echocardiography, sir, to
Fantastic.
assess fluid status.
Rapid obstetric screening echocardiography. Why it is done?
To assess the fluid status, sir.
Fluid status. This is performed by using the transthoracic echocardiography to assess the fluid status in the patient. Okay, so that is one of the things that you have to remember. Factors associated with development of preeclampsia can be maternal, first pregnancy, multiple pregnancy. Both can produce this. Donor insemination, molar pregnancy, chromosomal abnormalities, and maternal factors can be age, either 35 or more or less than 25, family history of preeclampsia, cooking, diastolic pressure more than 80, associated diabetes or other comorbidities like obesity, chronic hypertension, and antiphospholipid antibodies or factor V SLE like autoimmune problems. And paternal factors, first time father, sometimes the first pregnancy produces problem. And the life-threatening complications of PE are three things: hypertensive crisis, pulmonary edema, and eclampsia. And SIBA's criteria for ruling out or identifying true or complete self syndrome. Any idea about this?
The criteria for ELF syndrome, it has abnormal peripheral blood smear, sir,
Very good.
and LDH more than 600 international units per liter, bilirubin more than 1 to 2 milligram per deciliter, low platelets count less than 1 lakh, and AST more than 70 international units per
Very
liter.
good. So these are all things which have to be taken. And the complications, other than the life-threatening complications, common complications, cardiovascular system, there will be generalized vasoconstriction and decreasing circulating volume. Then there will be left ventricular failure, increase with vascular permeability and edema. The nervous system, it can have headache, visual abnormalities, vomiting, confusion, hyperreflexia. And cerebral hemorrhage due to severe systolic hypertension can happen. Convulsions because of cerebral irritability. The respiratory system, they can have generalized edema, we can have upper airway edema, and non-cardiac pulmonary edema due to capillary leak, very common in the respiratory system. The renal system, glomerular capillary endothelium and thrombi are present, so that will reduce the glomerular filtration rate. So the urea clearance, the uric acid levels are increased, and proteinuria and the hypoproteinemia are there possible. Oliguria and acute renal failure can happen. The liver, abnormal liver function, and subcapsular hemorrhage and rupture. This is the reason for the epigastric pain. If any pre-eclamptic patient complains of severe epigastric pain without relief with the usual analgesics, you have to suspect subcapsular hemorrhage and rupture. And the hematology, they can have altered coagulation profile with increased turnover of fibrinogen, fibrin, and platelets. There can be thrombocytopenia with impaired platelet function. They can sometimes develop DIC, disseminated intravascular coagulation. And health syndrome have all the changes like hemolysis and the low platelets. And in the fetus, the complications are decreased placental perfusion, placental ischemia and infarction. And the patient, the baby may be small for the weight of, so intrauterine growth retardation may be there. Placental abruption may happen. Preterm labor also is very common. And more common, these fetal complications are in early onset preeclampsia, which happens before 34 weeks of pregnancy. What are the controversial areas in the management? If preeclampsia develops at early gestation, when and how to one should what is the invasive monitoring? When will be needed? So, what are the indications for invasive monitoring? What are the benefits and risks of various antihypertensives that are used for this treatment? How should we manage an eclamptic seizure? Why is magnesium preferred over other anti-seizure medications like phenytoin and lorazepam and other drugs? How should we manage fluids? What is the platelet count safe value for neuraxial block? Is spinal subarachnoid block safe in severe preeclampsia? Should phenylephrine replace ephedrine to treat hypotension? All these things are considered as controversial areas in PAH, so we will see the answers for that. So the only cure for preeclampsia is delivery of the baby and the fetus. So we have to always take into consideration two things: maternal safety versus fetal prematurity. These are the two things which are to be considered. And in gestational hypertension and mild preeclampsia, patients can be managed at home. There is no need to admit them and monitor them. But at the same time, we can have them monitor their BP home itself with a home monitoring. BP monitors are available, so they can do that. And fetal surveillance is usually done by asking the mother to keep a what is called fetal movement count. How many times the baby kicks every day. So that is the most simplest method of controlling, assessing the fetal welfare. Whereas in severe preeclampsia, patient definitely needs admission. And if the patient has a favorable cervix, which means the cervix is dilating, and if the patient's the fetus is well matured beyond 36 weeks, then we can try a normal vaginal delivery by inducing labor. But without the labor analgesia, they should not be done because that can increase the blood pressure. So with proper pain relief and with no other obstetric contraindication like capillopelvic disproportion and a favorable cervix which is normally dilating, there is no contraindication for allowing the mother to have a normal vaginal delivery, provided the fetus is also stable. But if the cervix is not dilating, unfavorable cervix with adequate fetal maturity, better to go for elective LSCS or lower cesarean section. But if the fetus is less than 34 weeks and mother has got severe preeclampsia, like what we have given the case scenario, if it can be delayed for 48 hours for administering steroids for achieving fetal lung maturity, then that can be done. But at any time, if there is a threat to the mother, it should be abandoned and patient should be operated and the baby should be delivered as early as possible. And you can use magnesium sulfate infusion and IV antihypertensives to bring the BP to less than 170, 110. And if it is more than 170, 110, you should try to quickly go for IV antihypertensives. And HELLP syndrome should be treated with large doses of dexamethasone, like 10 milligram BD, to control the condition. And the dilemma that can happen is whether the maternal complication prevention is important or whether the fetal safety compromise is important. These are the two things. So high maternal BP can result in pulmonary edema or cerebral hemorrhage, and high systolic BP is a cause for cerebral bleed and stroke. So invasive monitoring is rarely needed since most of the patients are quite young with fewer chronic illnesses. But there are indications for arterial line. One is if the BP is consistently more than 160, 110, and if the patient is being given IV vasodilators like NPG or sodium nitroprusside, better to have an arterial line for a beat-to-beat monitoring. Or those who have coagulopathy and need frequent samples for checking the platelet count and other things, instead of puncturing them every time, you can have an arterial line from which you can take a sample. And those who are obese and very severely edematous, where non-invasive BP may not read accurately, they will also need to have an arterial line. And if there is a impending pulmonary edema and frequent ABG is needed, then that also is an indication for introducing an arterial line. Is there a role for CVP or a pulmonary artery catheter in hypertensive crisis? It is not normally used because the risk of bleeding is there. So it requires trained nurses to manage these central lines, but they are indicated in cardiac failure or pulmonary edema with a large alveolar arterial gradient, or patient in alveolic despite fluid resuscitation. And so in those cases, you have to put a central line also. What are the drugs that are commonly used in the management? This is another question that will be asked in the examination. Earlier, they were giving methyl dopa. Nowadays, very, very negligible percentage of physicians, because they are as old as me, they may be still using methyl dopa, but nowadays this is not being regularly given. And it is given by oral route, 250 milligrams to 3 grams divided doses. It acts as a false neurotransmitter to norepinephrine. It controls the BP. Side effects are postural hypertension, sedation, depression, bradycardia, etc. And contraindications in liver disease and risk of postnatal depression. So in these cases, better to avoid that. Labetalol is another drug which can be given by oral as well as parenteral route. It is given in 200 to 1300 milligram in divided doses. IV can be given as 50 milligram bolus followed by titrated infusion. And it is a combined alpha-1 and non-specific beta-adrenal receptor antagonist. The ratio of alpha to beta blocking effect is 1:3 for oral and 1:7 for IV. So it is a combined alpha-beta blocker drug. And the side effects of this drug are bradycardia, fatigue, bronchospasm, GI tract problems. It is contraindicated in asthma because of the alpha-1 blocking effect and cardiac diseases. Apromatoma, in all these cases, it better not be used. Nifedipine, this is a commonly given drug nowadays by most of the OB-GYNs. It is given orally, doses of 20 to 90 milligram, and it's a calcium channel antagonist. All of you know that. What are the types of calcium channels you have in the body? How many types of calcium channels you have and where are they present? Any idea? No one wants to answer that. The side effects are headache, dizziness, tachycardia, flushing, and visual disturbance. They are contraindicated in hypertensive and liver disease. Hydralazine is another important drug. It is usually very useful in controlling very high hypertensive crisis. Given only IV as a 5 milligram bolus dose followed by 5 milligram per hour infusion. It activates the guanylate cyclase and increases the intracellular cyclic GNP, leading to intracellular calcium passing, decrease the intracellular calcium, leading to vasodilation. Side effects are fluid retention, flushing, palpitation, headache, etc. Contraindicated in severe tachycardia. Then alpha blockers, they are all second line only. They are not the first line of drug. And the beta blockers, normally esmolol is the only short-acting beta blocker that can be used in severe hypertensive crisis. Otherwise, the regular beta blockers are not given. That may cause IUGR, so it is better to avoid them in pregnancy. Diuretics are used for edematous patients who have a lot of edema. You can use that to reduce the edema. Magnesium sulfate is a drug given for mainly control of seizures, but it also has a vasodilator property, so it can be effective as a antihypertensive also. The route and administration dose is a very commonly asked question. 4 gram bolus is given, followed by 1 gram per hour infusion for 24 hours, and urine output is low. And if you have a suspicion of altered kidney function, then better to reduce the dose of magnesium. Otherwise, you will go in for magnesium toxicity. Magnesium sulfate overdose will happen. And it acts in 3 ways. It acts at the calcium channel, reducing systemic and cerebral vasospasm. And NMDA receptor antagonism is there, by which it produces the anticonvulsant action. And increased production of endothelial prostacyclin, which also restores the thromboxane prostacyclin balance. So these are the 3 mechanisms of actions of magnesium sulfate. In the dosage of the serum level has to be very constantly monitored to avoid overdose. So between 2 to 4 millimoles per liter, you will have loss of deep tendon reflex. You will have blurred vision above 5 millimole. You will have respiratory depression above 7 millimole and cardiorespiratory arrest above 10 millimole per liter. And it is contraindicated in case of cardiac arrest due to excessive dosage of IV infusion of magnesium sulfate. First thing, you stop the infusion, start CPR, and immediately give 10 ml of 10% calcium gluconate, which is the important antidote given IV. Then send magnesium level assessment to the lab, and if the patient is using nifedipine as an antihypertensive in the antenatal period, be very, very careful in administering magnesium sulfate because both can act synergistically. And magnesium crosses the placenta to cause neonatal hypotonia and respiratory depression. These are all the side effects of that. And various regimens that are being used is also asked in the examination. And the regular dose is 4 grams followed by 1 to 2 grams. And in case of recurrent seizures, if it is happening, at the time you can give a bolus of 2 to 4 grams again at the occurrence of seizure. And if seizures are not abolished by giving this excess dose of or the bolus dose of magnesium, then patient may need airway support and ventilation. So you have to caution the ICU and get the patient ready there. And 44% of eclamptic fits can happen after delivery also. So we have to keep a watch on the postnatal period also. So this is the common question. What are the various regimens of administering magnesium sulfate? One is called the Pritchard regimen, where first 4 grams is given IV, the loading dose. And immediately, it's given intramuscular regimen is 4 grams intravenous as a loading dose, followed by 10 grams intramuscularly, then 5 grams intramuscularly every 4 hours in alternate buttocks. So starting with IV, you follow it up with intramuscular at a very, very high dose, that is the Pritchard regimen. And the juice band regimen, which we normally follow, is a 4 gram IV bolus followed by maintenance of 1 to 2 gram IV as a controlled infusion. This is the common method now we are practicing. And there is another newer regimen called Solapur regimen, where 4 grams IV bolus is given, after which you give 2 grams intramuscularly every 3 hours in alternate gluteal period. This is available as a 50% and 25% vials, ampoules in 5 ml and 2 ml. So this is how you use this particular drug. And describe the steps in the management of patient throwing a fit phase, administer high flow oxygen, turn the patient to right or left lateral, introduce a bite block, suction and clear separation. All doses of thio or propofol can be given if the fluid is very violent. Additional 2 grams of magnesium sulfate also can be given. And CT MRI, if seizure is recurrent, to rule out any cerebral hemorrhage. If it is a single fit, you can ignore that, but if it is recurring, then better to go for a CT MRI. Consider delivery either by induced, if the patient regains full consciousness, then you can induce labor and try for a normal vaginal delivery. Otherwise, better to go for cesarean. Coming to the fluid management in these patients, have a contracted vascular tree. That's one of the important things. Second is they have leaky capillaries, causing pulmonary edema, compounded by reduced plasma albumin also due to dilation. And always better to err on the less fluid side so that you don't overload the patient. Should not exceed 1 ml per kg per hour. Monitor the urine output and see whether they are producing 5 ml per kg. It's accepted minimum. And co-loading is preferred to preloading during central neuroscal blockage. So preloading like normal patient should not be done. Coming to the delivery management, time and mode of delivery depends on the severity of the preeclampsia and the gestational age of the fetus, which has been the point of discussion all this time. And the decision to deliver largely depends on maternal rather than fetal well-being. Coming to the choice of anesthesia, can be regional technique wherever possible in most cases. And hemodynamic stability after spinal is quite comparable. So earlier days we were thinking that regional should not be administered, but nowadays that recommended technique is only regional. And the advantages of labor analgesia for this patient is it helps to control the blood pressure because there is no pain perceived, improves placental blood flow by the vasodilatation that it produces, abolishes labor pain, and can be extended to provide operative anesthesia if suddenly the indication changes from normal vaginal delivery to operative delivery. The disadvantages are it is not suitable in patients with low platelets or bleeding coagulation profile is altered, which can result in hematoma formation. And if the patient is very edematous in the control region, the technique of introducing the epidural catheter may be quite challenging for the landmarks will be different. Coming to the challenges during general anesthesia, what are the indications for GA is there is a coagulopathy where regional cannot be administered, or patient has a obtended level of consciousness because of seizure, or there is a threatening or impending pulmonary edema with a hypoxia, or patient refusing all the indications. And the most important danger of GA is the pressure response to laryngoscopy and intubation. So the surge of blood pressure during the time leads to intracranial hemorrhage. The patient may not recover at the end of anesthesia because of the problem of intracranial hemorrhage. So the measures that we have to take to attenuate this surge in blood pressure are can give a bolus of magnesium or labetalol, the more potent opioid like fentanyl, then try to control them. The normal techniques of giving IV Xylacard or esmolol are not recommended in these cases. Because esmolol can be given because it is very short acting. But here they recommend labetalol compared to the non-hypertensive cases. And the routine steps that you have to follow here are antacid and antiemetic premedications to be given because all pregnant women are considered as full stomach patients. And whatever antihypertensive and anticonvulsive drugs should be continued. But I heard Ranjini saying AC inhibitors. AC inhibitors are not given the routine for pregnant women because it can have a teratogenic effect. So AC inhibitors are not prescribed for pregnant patients. So don't say that in the exam. And so normally they are given or labetalol. And the intubation may be difficult due to edema of the upper airway. So you should have a difficult airway chart and be prepared for facing that. And there may be decreased pulmonary compliance. If the woman has received magnesium sulfate, you are going to use muscle relaxants, then you have to monitor the neuromuscular tension function. And routine use of ergometrin or symptometrin should be avoided because that can increase the BP. Avoid NSAID because that can affect the renal function. And paracetamol, if the patient has any significant liver dysfunction, avoid paracetamol also. So depend on the fentanyl opioid like fentanyl or any fentanyl which is available nowadays. And use of magnesium sulfate itself has got analgesic property. So the requirement of analgesia will be much less. In addition to that, you can go for your facial plane blocks like tab block or paravertebral block or the other anterior and posterior wall abdominal wall blocks can be practiced. Now the allied topics or questions that may be asked are physiological changes during pregnancy, anemia complicating pregnancy, anesthetic management of elective or emergency ACS, obstetric patient coming for non-obstetric surgery, management of antepartum and postpartum hemorrhage, labor analgesia, the various techniques of labor analgesia, newer inventions in that, neonatal resuscitation, uteroplacental circulation, anatomy and physiology, all the questions that can be asked as a allied questions in the examination. Okay.